Hello everyone, welcome to the 10th Annual Summer Public Health Research Institute and Videoconference on Minority Health. It's my pleasure this afternoon to introduce our first speaker, Dr. Bill Jenkins. Dr. Jenkins is Professor of Public Health Sciences at the Morehouse College and Associate Director of the Research Center on Health Disparities at Morehouse. He received his bachelor's degree in mathematics from Morehouse College, master's degree in biostatistics at Georgetown University, his master's of public health and Ph.D. at the University of North Carolina. For 2 decades, Dr. Jenkins served as supervisory epidemiologist at the CDC's National Center for HIV, STD, and TB, and also managed a program that assures health care for survivors of the Tuskegee study of untreated syphilis in men. Dr. Jenkins serves as the governing counselor on the American Public Health Association and is also on the board of directors for the American College of Epidemiology. Today, Dr. Jenkins will provide a critical look at our current approaches for addressing health disparities and offer some solutions for how we can reconceptualize how we address this issue. So please join me in welcoming Dr. Bill Jenkins.
Thank you. I am going to try to move quickly through these slides because I'd much rather have an exchange doing a discussion during this presentation. Some of the things I'm going to say may go against the grain and the conventional wisdom, and so I think it's important for people to have an opportunity to ask questions about what I said or what they thought I said. So I'm going to go through this very quickly. First, what I'd like to do is to talk about infant mortality over the last 100 years here in the United States. As you know, infant mortality is the most commonly used single variable for assessing the health status, the overall health status of populations. And so what I'm going to ask some of the people here in the audience to do is to simply indicate what they think the rate ratio, in other words, comparing black to white babies dying in the first year of life. Infant mortality is the rate of the number of black babies born in the first year of life divided by the number of babies who were born alive. And I'm just going to ask a simple question, whether you think it was 2 times greater for blacks, 4 times greater, 8 times greater, or 16. Very simple. So in 1900, and everybody has to, you only get an F if you don't raise your hand at one of the options. But in 1900, what do you think the rate ratio was? Was it 16 times greater for blacks than whites? Anybody? 8 times? Anybody? 4 times? Anybody? 2 times? Ah, okay. In 1940, what do you think it was? 16 times? 8 times? 4 times? 2 times? In 1980, what do you think it was? 16, 8, 4, 2. In 2000, what do you think? Is it 16, 8, 4, 2? Well, a lot of you got it this time. Most people don't even come close. This is a very bright audience. Yeah, that's what it is. Okay. The infant mortality rate has gone down drastically over the last 100 years, but the rate ratio has remained at 2 for the last 100 years. We have tried all different attempts to try to solve these problems of health disparities here in the United States. And we've essentially done the same things over and over and over again, expecting to get a different outcome. And I think people know what happens, what we call people who do the same thing over and over again and expect a different outcome. So that really tells you something about what's been happening with health disparities. And it's interesting that in the last 2 years, the rate ratio has gone up a little. And interestingly enough, that's of course associated with the increase in college education among black women. And I think one of the interesting small points here is that I think most African Americans thought that by becoming educated and middle class and everything that the health of their children would actually increase rather than decrease. And what we've found out is, of course, that it has been stress that's caused this slight increase, and we'll come back to some of the issues around that. So what we think is going on here that people don't talk about a whole lot is that we think the model indicates that about 30% of the health disparities is probably due to socioeconomic status, that a little less than 30% is due to racism, another 30%, maybe 20%, 30% due to culture. This is a very ill-defined variable, and we'll talk about why that is the case. Less than 10% of it is probably due to health care, and yet, of course, that's where we're putting most of our conventional wisdom tells us that that's where we should put most of our resources, and that's where it's going. So the bulk of our resources are going into areas in which would have minimal impact on health disparities. And then there are biological factors which may account for as much as 1% of the health disparities, and that has to do with the lack of understanding of something called race. And it's a long and complicated discussion, so I won't get into it, except to say that in some audiences, one of the things we go through is have, two black students and a white student to stand up and ask the class which one is most likely to share, be closest in terms of the genetic makeup. And of course, the answer is the black student and the white student, one of the black students and the white student, are far more likely to share a common or similar profile than the two black students. And the reason is that Africans are the oldest population on Earth, and that their variance in genetics is huge compared to other groups. And so it's a simple phenomena. It's just that people don't tend to get that, unfortunately. And so I'm going to talk about racism a little bit because it's one of the major factors that determines this. And it's still a pervasive force. But what our young people are going to have to face, when I came through in the 60s, we had to deal with signs on buses. The issues that we had to face were very clear. Young people are going to have to deal with this whole issue of white privilege, where whites gain a certain advantage without really having to do very much to take advantage of that advantage. And yet many middle-class African Americans can see it, or many African Americans can see it, and become very upset about this process. But it is a factor that actually is going to be far more difficult to deal with over the next few decades than the obvious kinds of racism we've had to deal with in the past. A lot of this rises from this term race, which is something that everybody thinks that they understand what it means, and yet very few people do. And one of the real problems, and I won't go into all that discussion either, except to say that as people use this term race, it justifies racism. Racism is based on the concept that race has some validity to it. And one of the real problems is, of course, that African Americans believe in this concept called race. And so as African Americans continue to support this concept, racism will continue and it will not be abated in any great degree. And so the struggle with this whole issue is going to be something that we are going to have to struggle with over quite some time. The other thing that, you know, as we have been having these discussions, as we've talked around the country, we've found that many people are just afraid to use the word racism. You know, one of the things that we say is that there's no race problem in America, there's a racism problem in America. But many people are just afraid to use the word, especially African Americans, just afraid to use the word because it sounds so judgmental. And maybe we can come up with another word, I don't know. But the fact of the matter is, right now we have to use this word in order to define what the real problem is, because if we use the term race to define what the problem is, then it suggests that it has to do with some phenotypic characteristic that I and some of the people in the audience have, as opposed to this problem of racism. And the other point I wanted to make was that many intellectual Negroes will say that race is a social construct, and it might be. I just spent a few days at Harvard, and I know that my friends there will tend to say that race is a social construct. But the minute they go over the Charles River into South Boston, I can assure you that the people there don't see it as a social construct. It is a biological one. So 99% of the people in America see it as a biological construct. So the fact that, you know, you have 8 or 9% of the people saying that it's not, is not going to be all that meaningful in misusing this term. And so what we think is the really difficult problem about using this term is that it gets that we focus on issues that are not really the problem, like genetics. And we leave off the 3 elephants in the room that I want to mention again: socioeconomic status, culture, and racism. Those are the 3 big elephants in the room that we have yet to spend sufficient time on to really try to resolve this problem. Now, one of the interesting things about this, of course, is culture. Because we use this term race, we don't see African Americans as culture. And the example that I give is that in the Atlanta University Center, we have these dance competitions between certain tribal groups, you know, Alpha, Omega, Kappa. And these tribal groups do competitive dance for the same reasons that Africans have been doing for the last 2,000 years. Which is to attract young women, basically. But it is amazing how similar these competitive dances are, and for the same purpose and in the same manner. And so culture is a major factor that we still have with us. It explains the issues of nutrition and to some degree. It explains the issue of healthcare utilization in certain ways. It explains the issue of health-seeking behaviors from other sources other than traditional medical sources and so on. There are just a whole lot of questions the culture will answer if we ever get to the point of studying culture as a major factor. For example, one of the issues in health care is that people think that the issue is accessibility. And conventional wisdom says that, you know, the real problem about health disparities is the lack of accessibility. Well, research is not showing that to be the case. There's sufficient access to health care for most African Americans in this country. What is really the issue is that many of these services are not acceptable. And so what you'll find is that many poor people, for example, among Medicaid users, they will bypass hospitals in order to get to a hospital that they feel comfortable with, that they find where they're accepted in terms of their culture. And so this is one of those misunderstandings. So we aren't spending the time understanding acceptability of health care, and we're spending a lot of time analyzing accessibility of health care when acceptability of health care may be the bigger issue. One of the things that has been going on in the last 10 years is we've actually been shifting data collection from race to ethnicity without people realizing it. Because now when you fill out the census form, for example, you check what you believe your identity is, rather than somebody, a census taker, coming to your home and checking it for you based on how you look. And in the next census, you're going to have more of an opportunity and variety to check different subgroups within the larger groups that we've had, that we've used in the past. And so we've really been collecting ethnicity now for about 10 years, but unfortunately we still use the term race because we know that people are used to that word rather than really the shift that's already occurred. In solving these problems of health disparities, issues of trust and competing risks and internalized racism still need so much work until we're just beginning to do that. I won't go into that. There are a lot of people, there's a lot of literature around to indicate how much more work we need to do on this issue. So I know I'm going fast, but I want to, try to get to a point of discussion. Now, SES is probably the most powerful force to determining health disparities. It's probably more than 30%. But in this country, there's no real will to solve the problem of socioeconomic status. So that's not going to happen in the structure, the economic structure that we live in. But what we're finding, of course, is that there are solutions to reduce the impact of SES through interventions that seem to work. Head Start, for example, the most glaring example. But by specifically focusing on public health prevention programs to specific communities, we also can change the impact of SES by making that community a part of the process. Now I want to go through a couple of examples here of things that gives us a clue about what we should be doing. This is HIV. It's a very interesting disease, as some of you already know. Very early on in the epidemic, around 1984, it was clear that African Americans were at increased risk of HIV disease. But most people did not want to accept that. Most African Americans leaders would rile at any of us who would suggest that African Americans were at increased risk, even though the rate ratio at that time was somewhere around 2.1. The AIDS epidemic has continued to increase, particularly in the African American community, over the last decade, or a little more than a decade. And now we see the rate ratio has gone from approximately 2.1 to greater than 7.3. Now, some of us predicted that in 1991. It was clear that that was going to happen, but again, people were not ready to listen at that point. What is important to understand about this epidemic and why this rate ratio has increased, though, is that most efforts regarding HIV disease were focused generally on the American population. And there's a phenomena that's quite simple, but people, again, sort of miss it sometimes, which is that if you provided the same resources to a high resource community and a low resource community, that high resource community will pick up that intervention much quicker than the low resource community. The result is the disease rate will go down faster in the higher resource community and less fast in the lower resource community. So that if you were to provide a public health intervention equally in a low resource community and a high resource community, you will increase health disparities. Now that sort of goes against conventional thinking, but that's exactly what has happened and what we've seen in the AIDS epidemic. So as long as our emphasis is on providing an overall prevention program rather than a very specifically targeted one, you will find that the rate ratio will continue to increase in the African American community. And the new initiative, of course, which is early testing, you will begin to see that this rate ratio should increase even more in the next few years, unless specific programs are developed. Now, in the 1990s, when some of us came back to CDC, we wanted to look at how we can involve the community, because we thought that was an important part of this process, in eliminating syphilis. We chose syphilis because not too many people were interested in it. It was a disease where, it was easily diagnosed, easily treated, and so on. So the important thing was this intervention of getting the community involved. And as we implemented a program that involved the community into the process of eliminating syphilis in this country, the more we involved the community, the more the rate went down. So one of the real interventions that we think is really important is to include this issue of community participation, which is not easy at all and is fraught with the possible errors. We then looked at these levels of community participation. There's community notification, which just says, we're here. Community endorsement, where you might get, a leader or a politician to endorse the study or the intervention that you're doing. You get community advice, form an advisory committee to get some advice from the community about how to implement. Then you could seek community consent, which is even a higher level of community involvement. You go into the community and you say, we won't do this study unless you approve of the way in which we're doing it. And then finally, community origination, which is to work with the community in a way that we define what it is that they want to do and then proceed to do that work. Now, these are pictures from the Tuskegee study of untreated syphilis in the Negro male. One of the most well-documented studies in public health research. It's a very misunderstood study. For example, when people will often use the word Tuskegee experiment and think that they're talking about the Tuskegee study. These are two entirely very different things. But unfortunately, it speaks to this problem about history, in that the Tuskegee experiment is probably the most progressive economic development program in the history of Black Americans. But most Black Americans don't know that now, because the one thing that people know about is the Tuskegee study of untreated syphilis in the Negro male. And so the result is, when people now say Tuskegee experiment, they think you're talking about the Tuskegee study. And it's very unfortunate, because this little town changed Black America, created the NMA, the National Bar, National Nurses Association. All of these activities came out of this community, and yet all of that is forgotten. And the only thing that's remembered is the one bad thing that happened. And this is one of the real dangers about community participatory research, because when you go into the community, you may do a lot of good, but people will remember the one bad thing that happened and forget all the good that may have been done. But here's Nurse Rivers recruiting men for this study. And they used all the institutions in the community, the churches, Black businesses, and Tuskegee Institute, and so on. Now, so that the Tuskegee study of untreated syphilis in the Negro male utilize all levels of community participation. They notified the community about this study through churches and businesses. They got endorsement from the business establishments in the area. They got advice from the Tuskegee Institute. They even got community consent from the physicians in that community, most of whom were African American. And they had a high degree of, there was also really resulting out of community origination, because the original idea was to go in and treat syphilis. Unfortunately, it resulted in this, this assessment of untreated syphilis. And then finally, it is a study that was done with a high degree of cultural competence. That's why they studied these men for 40 years and had a loss to follow-up of less than 17%. I don't know anybody who does community research, but you will know that to follow a group of people for 40 years and to lose less than 17% of them is an amazing accomplishment. Now, one of the things we have to do, or at least some of us have to do, is to try to think through objectively when looking at an issue like this, to learn from it, as opposed to the emotional reaction that so many people tend to have about things. It is important that we learn from all our experiences so that we could solve the problems. And there are barriers to community participatory research. Respect for community competencies is something. There's still a problem, for example, of classism, here within the black community and within America. And so the fact that these were poor men had an impact on what happened there. The willingness to share power. This is very difficult. People don't generally want to do that, and somehow our institutions are going to have to learn how to do that. And then learning how to accept another's perspective. This is probably the most difficult, because all of us know exactly what to do, what all the answers are, and people who disagree with us are simply too ignorant to understand what the real solutions are. So we've talked about some of the things that we could do already, so I won't go over that, but except to say that one of the things that's so important is that we target resources to the problems rather than target resources to what we think the problem is. This is a picture of a group of African American women epidemiologists, including Dr. Vijaya Hogan, who did some of the groundbreaking work on this whole issue of stress in African American women and the issue of preterm delivery. When you go to an audience now and you ask, why is it that the infant mortality and rate and the preterm delivery rate among college-educated black women is so high, many people will tell you it's stress. But before that work, very few people would have said that. And now everybody, now it's become conventional wisdom, I guess. So those are the major points I wanted to make very quickly, because I really wanted to have a discussion more than I wanted to have a delineation of all of these issues. And there are background to each of these issues, but it would have taken even more time to try to go through them. So I'd rather respond to questions than based on what your interest is, rather than spend time going through each one of these. So, thank you.
We'd like to invite questions from our audience, both our in-house audience and also our participants outside of the UNC Chapel Hill. The phone number where you can call in questions or fax in questions will appear on your screen momentarily. So please call in any questions that you might have. There's also the opportunity to email your questions, and that number is also on the screen as well. Any questions from this audience?
Yes, ma'am.
Thank you for coming. I'm so happy that you're here. I have a question regarding, I'm very interested in the stress that African Americans go through and how it might affect healthcare. I'm wondering how much study or what your thoughts were about the legacy of mistrust and its role in why African Americans may not go to the doctor, why we may skip that hospital because we don't feel a trust with the doctors, and also how right now with Healthy People's 2010 and a lot of the research requiring that African Americans be a part of that process, how we then go about getting African Americans to participate in research when there is a valid mistrust of both doctors and scientists.
Right. It's a real toughie. Well, the first thing I want to say, I think it's insulting to African Americans to think that African Americans don't trust the medical care system because of one study. There's a long history. There are a lot of reasons why African Americans don't trust the medical care system or the federal system for that matter. And so what really needs to happen is not so much a sort of a propaganda campaign against poo-pooing the concerns of African Americans around this issue, but a real concerted effort to actually earn the trust. I think it's Barnes and Noble. There's an investment company that says we earn your trust or something like that. You have to work for it. And I think most people are not willing to do that. Most people want to assume it. A lot of people believe that they can get trust by simply hiring African Americans. But I can assure you, given my years of experience, that melanin is no vaccine against racism. And melanin does not provide an automatic cultural competence. African Americans need to study cultural competence as well. There's a lot of people who study African Americans and jump to the conclusion that because they've studied African Americans, white and black, who think that they then know African Americans because they've done this study. This takes work, it takes sensitivity, it takes effort. And so the first thing I would say is that trust must be earned, and there must be concerted efforts to do it. And it won't be a cheap, simple way by simply hiring a black person to be the front for whatever activity that you're going to do. I think participatory research is a way in which one can achieve that trust by working in a community before you even begin to do the research. But the other thing is that who you select in the community is important. Many people would like to pick the person that's easiest to work with. Sometimes the most important person that you should include in your participatory effort are the people that's most difficult to work with. And I think, for example, one of the real problems that we have today in terms of institutional review boards, now, you know, as a result of the Tuskegee study, we've set in motion a number of safeguards against misuse of research. And one of those is institutional review boards. But quite often, the community members of institutional review boards are connected with research. They may be the wives of somebody who's doing research or the niece or something like that, but they don't really represent the community. So finding people in the community who actually represent community interests and then putting them on the IRB, even if it requires additional training and effort, that is what's going to make a difference in the long run, making a real effort to work with the community. But there's still, a lot of work to be done, and we're beginning to at our research center, develop a training program for community members of IRBs so that they could become more supportive. Because one of the things you find out is that many people, like my beloved brother, who will tell you, I'm a doctor. You're supposed to listen to me because I'm a doctor. Well, that's not enough. And we've got to listen to the perspectives of everybody in the community. They may not be an expert in medicine, but they're an expert in their community.
We have a question called in, but before I get to that question, I'd like to remind the participants the phone number to call in your questions is 877-869-7811. The fax number is 919-966-7141, or you can email your questions to question@unc.edu, and these numbers are on your screen. We have a question submitted by David Mount from the Department of Health Psychology at the University of Missouri. And his question is, in terms of behavior change, Dr. Jenkins, what might be some of the factors affecting readiness to change attitude and motivation for African Americans and other minority groups? For example, health literacy, financial resources, cultural identity, development, trust, etc. So what might motivate African Americans to change behavior?
Well, the same thing that motivates European Americans to change behavior, self-interest. I think that there are a number of things that one can do to make certain that people understand, for example, that it is in their interest to make certain changes. And I think that that's where health education comes in. The problem, of course, is that if a health educator goes to a mall and say to somebody, give me $5 and I'll tell you how you can protect your health and maybe add another 15, 20 years to your life. And what do you think the person in the mall is going to say? $5? Are you kidding? But then get that same person a heart attack. He's lying in the hospital bed. A surgeon comes in and says, okay, sign this for $5,000 for me to cure you, and they'll sign it. The problem is that the priorities that we have is somewhat askew, and what we have to do is, through public means, I think is the only ways of doing this, is to provide resources to those activities that could do things like help people change behavior. But quite often it's not so much the people who do not want to change their behavior, but it's the issue of competing risks. Many people will say, I gave this black man an appointment to come in and get his lab work done, and he didn't show up. Well, that black man might have been called for the first time in 2 weeks for work that day. And he's going to have to decide between going to work, on a construction site and making some money, or going in and getting this lab test. Well, you know what he's going to do. It's not that he didn't want to go in for the lab test, it's that he had to go in to do some work. And so we don't appreciate the competing risks that other people have in their lives. We presume that everybody should act like nice little middle-class people, and that's not possible for people who have very real restrictions on their lives.
Okay, thank you, Dr. Jenkins, and thank you, Dr. Mount, for your question. We also have a follow-up question from Dr. Mount at the University of Missouri, and his question is, young minority researchers might be concerned that publication of health disparities research is not respected or seen as valuable in the top-tier journals. Journal reviewers comment that this topic may not hold the reader's interest. Do you have any specific recommendations for how you can address these types of reviews?
Keep going. When we started in 1991, people may not remember this. There was a health disparities report in 1986 by Margaret Halkler, actually a lot of the work done by Al Haynes, Dr. Haynes. Those 6 or 7 reports essentially landed on people's desk and then landed in people's trash can. So by 1988, 1999, health disparities was not a major issue. What happened in 1991, as you know, a relatively small group of about 20 epidemiologists, black and white, got together and decided to look at this issue of health disparities, to look at issues like racism, to see how it impacted on health disparities. The result was that these individuals, like the group I showed you, produced some groundbreaking work on the issue of health disparities. Now health disparities are seen as this big research area that people ought to be looking at. And so the way in which this publication community and the research community gets changed is really by people continuing to do the research that needs to be done, even if they won't get respected. And let's face it, I mean, the fact of the matter is there's some issues and some people who are always going to be more respected than other issues and other people. You have to have a commitment to the work. And quite often, it won't be that you will be praised to the level that you think you deserve. And yet, somehow, I think you have to keep going. You have to remember the little patent clerk in Austria in 1917 who suggested something as ridiculous as E equals MC squared, and everybody laughed at him, thought he was stupid, but he changed the world. Or another little chemist who had a job of trying to understand why some wines taste differently than other wines, and found out things like pasteurization, which keeps his name alive. Louis Pasteur was not a physician, and people disrespected him as well. But it is the ideas that count. As Martin Luther King said, the world arcs towards truth. It's a big arc, but it arcs toward truth.
Thank you. We have a question from Minneapolis, Minnesota on the phone. Can you go ahead, caller, please?
Hi, my name is Sandy Johnson. I'm calling from Minneapolis, Minnesota. Dr. Jenkins, I have a question regarding the Institutional Review Board.
Mm-hmm.
How does one access that process as a community member?
Right. Beautiful. Thank you. Go and find out from the university where it is. They have to tell you. Go and sit in the room and keep sitting in the room. I cannot tell you the number of times, I have walked into a room in which people would immediately say, "May I help you?" And now I get the impression that "may I help you" is a curse. You know what I mean? Somebody is really trying to, get out of the room. That's what I'm hearing after a while. But, and there are some universities that will have an open door if you show a real interest in an IRB. But there's an IRB coordinator at each university who gets government funds. You can talk to that person and express your interest. It may be that you will run into somebody who actually wants real community people on an IRB board, and it's done. On the other hand, if you walk into a community or university in which you're not welcome, then I say just go and sit in the room and listen to what's going on. They, I think, will eventually respond. People have a way of understanding that there are people who will be persistent, and therefore it's easier to just give them what they want. There are people who will come in and be distracted at the first possible thing that comes up. If you're persistent, you will be able to get on an IRB. I believe that. But thank you. That was a wonderful question.
All right. Thank you, Dr. Jenkins. I have another question also.
Mm-hmm.
I currently work for the Minnesota Department of Health, and the University of Minnesota is across the street.
Mm-hmm.
So we have the medical school as well as the School of Public Health. So do I just call and say, is the IRB funded by the government, or is
it's at, trust me, it's there at University of Minnesota.
Okay.
Trust me, I just had a student to finish there. Yeah, it's there.
Okay.
Yeah, and she had to go through it, so I know it's there.
Could I have her name? Is there a way I
If she wants to just send email.
or maybe I can...
Yeah, send an email and I will get that information to you.
Okay.
Yeah.
Send the email to you?
Or send an email to...
question@unc.edu, and we'll make sure Dr. Jenkins gets it.
Questions at...
UNC.edu. UNC.edu.
UNC.edu. Okay, I
Thank-
will do that today. Please do not forget me.
Thank you for your
Thank
call.
you. Thank you.
And I encourage other participants to please call or email in your questions. And I'd like to invite questions from the in-house audience.
Hi. I'm an
Please
epidemiologist.
Say your name, please.
My name is Whitney Robinson, and I was interested in your discussion about research into health disparities, how there's a model where a lot of factors like socioeconomic factors and racism figure in, but research is focused on other things. And I think a lot of epidemiologists have a hard time approaching these factors because they seem so interrelated and complicated and hard to separate. And on the one hand, you know, you're trying to separate them. On the other hand, there's the danger of oversimplifying by picking out one piece. And do you have any advice for dealing with those kind of issues?
This is just going to be work. This is just going to be, and I love your introduction. I'm an epidemiologist. That's great. I love that one. There are a lot of people working on it. Nancy Krieger on SES, you know, and people are doing parts of it. And somehow we're going to need to get together to talk about how to divvy up the work. It's almost like the Human Genome Project. That's how we're going to have to think about this. And it's going to have to be like the original Human Genome Project, where it's a bunch of not well-funded people trying to put it all together and using PCs to do the work. You know, when the big boys got in because they started seeing money, something else happened. I won't go into all that, but you know, but if each of us are working on different parts of it, I think we'll put enough clues together to put this into a framework. And that's why I spent time trying to set up that model. The model might be off. It may be 24% rather than 32%, but at least we have something to look at in terms of framing the questions and trying to understand. And then you got to understand there are many variables within those factors, as you know, and many of them are highly correlated and interactive. And so, yes, there's going to be a lot of work. But that's the beauty of it, you know, that there's going to be so much wonderful work to do. You know, I was afraid that we would have solved all the problems before young people got into epidemiology. I'm not afraid anymore.
Hello, my name is Moon J. Fo, and I'm a student. I was just wondering, in a research methods class that I took, we were talking about statistics and comparing minorities to whites, and how you made reference to how in prior times officials from the census would, you know, come and knock on the door, and they talked about how there were problems with that because minorities tended to be less responsive to white officials. And then when they changed the system over to where it was sort of a self-response, and it was you took the responsibility upon yourself to send it back, then there was a problem of low response rate. So how, and I think you introduced yourself as a biostatistician, so I hope it's in your realm, but so how relevant is census data for the health of minorities in America, and how accurate, how much can we rely on it?
Right. Well, it's as accurate as most other things. I hate to tell you this, but when you go out to a nightclub and somebody tells you how much money they make, they may not be making as much as they tell you. So, you know, people are often not, totally honest. But it is the nature of the way in which we collect data. So I think that it's as good as most other variables. But what we've got to do is understand it as ethnicity rather than race. And then I think once we do that, we'll have a better understanding of how these variables play out. If you think that because you could look at two people and they may physically look like each other and be quite different culturally. And so we really know more about people by what they chalk off as their cultural identity. And so I think it's more accurate than what we've been doing before, and more meaningful than what we've been doing before.
Are there other questions from the audience? Dr. Schoenbach?
Bill, thank you for a very thoughtful presentation. I actually have several questions that I've written down there, but let me just start with one. I want to be sure that I understand. You said, I thought at the beginning, well, first of all, to confess, the reason that I knew the answer to the infant mortality ratio was because you used it back about 10 years ago or something like that at APHA, and I remembered it.
Oh, okay.
But I thought I heard you say that African American women who got more education had higher infant mortality rates, and I wonder if really what you meant is that they had a higher ratio compared to white women with more education.
Right, that's what I meant. The rate ratio, especially in preterm delivery.
But it's not as if getting more education was bad for them or for their offspring.
No, when you compare high education women to low education women, the babies are healthier. But when you compare college educated African American women to college educated European American women, then this is where you see that gap. But the two rates are much lower.
And since you're admitted to being a biostatistician, why is the ratio the better measure of the existence of the disparity than the difference, which, according to the slide, was getting smaller?
Yes. Well, the model, we're suggesting the attributable risk percent as the variable that we would like to be able to use. It's just that working with audiences, people find the rate ratio a little simpler. To say 2 times or 5 times or 8 times, people can understand that immediately. If I had used attributable risk percent, I think that people would try to figure out what the numbers meant rather than the point I'm trying to make, which is simply that these health disparities have not changed very much over the last 100 years.
But even if you use the attributable risk percent, that's still based on a ratio,
right?
Fundamentally,
right.
And the nature of a situation is when you have the improvement of 2 curves,
right?
So the lower one is getting lower. That will tend to bring the ratio up rather
right.
than down.
Right.
And so it's often the case that when you see improvement in 2 trajectories, the ratio between them gets bigger. And I'm not sure that that indicates that the disparity is really getting bigger.
But that's only if the uppermost slope is not the same. If the slopes are the same as they should be, if everything was equal, those 2 slopes would be the same.
Well, right, and so that might be, one might say that's what you had with the infant mortality ratios, that the ratio did not change over the 100 years, but there was a dramatic improvement in both curves.
No, if the goal was to try to reduce the slope, to change the slope, and the slopes did not change. In other words, when people talk about health disparities and what they've been trying to do, and this is the difference between looking at health and looking at health disparities. But if people if the goal was looking at reducing health disparities, as has been said time and time again, then the slope should have decreased faster among those whom that intervention was being targeted, and that didn't happen. And we saw it with syphilis that it can be. That slope can change. You can actually change the slope so that the disparities actually decreased.
Mm-hmm. Well, I don't know that I would agree that the disparity has been on the agenda for the whole time of your graph. I'm sure you'd agree.
Well, let me put it this way. It was on our agenda. It may not have been on anybody else's.
I don't want to monopolize the question, so if there are other people, let me know.
Yes, well.
If there are other questions in the audience, I'd be happy to take it. And I'd like to again remind our participants outside of this room to please call, fax, or email in your questions. We do have a couple of questions that were emailed in. One is, Dr. Jenkins, what role do you see public health and medical providers playing in addressing SES or the effects of SES, since you cited it as a major contributor to disparities?
Right. The number of examples of interventions that can compensate with regards to SES has been limited. When we look at supposedly controlling factors like Medicaid, where everybody has some health insurance, or at least within that population, blacks and whites have health insurance, we still find that gap fairly substantial. So what I am saying that might be helpful is, the first thing is to ensure that health providers create a welcoming environment. I worked in STD for a number of years, and I have to say that I have walked into some STD clinics that I wouldn't go to. You know, it's not that it was terrible, they would treat you and you'd be cured and everything, but the fact of the matter is it wasn't a very welcoming environment. And I think that many healthcare providers can do much to increase their cultural sensitivity to people. And we've seen that especially among Hispanic Americans. We've seen changes in the availability of translators and so on. That's made a big difference in the way in which Hispanics have felt welcomed in clinics. And so we've seen some of the things that, that work, and we need to try to find other interventions that work. But there's still a lot of effort needs to be made in that area. I do think that we need to, this whole area of looking at acceptability as opposed to accessibility is something we really need to spend time doing research on. And very few people are looking at acceptability. They're looking at accessibility. So the research needs to be far more than what we have said. There's one other point I wanted to make. What is the single most important individual who determines whether a patient feels welcome in a clinic? Anybody has any idea?
Just people at the front desk.
That's right, the receptionist. You know, it's not the nurse or the physician, it's the receptionist who determines. So who you have as a receptionist, these are things that people didn't think about. They think, well, if I just provide good care, then they should feel welcome. Well, you know, that's not the case. So a lot of things that we need to look at.
Thank you. We have a call coming in from Pittsburgh, Pennsylvania. Please go ahead, caller.
Yes, good afternoon. My name is George Mitchell. I'm a M.H.A. student at the University of Pittsburgh. And my focus is in policy. And oftentimes we address the issue from the behavioral health standpoint. But as a future policy professional, what are some of the things that I can look forward to trying to implement or put into place that will make a dent in healthcare disparities?
And healthcare disparities, not health disparities.
Health disparities.
Health disparities, okay. Now I have to confess, health policy is one of those areas where I have not concentrated a great deal. I think if you did a 2x2 table and you put money across the top and policy at the bottom on the side, and you look at money says do something and the policy says do something, it gets done. If money says do something and the policy says don't do it, it often still gets done. If money says don't do something, policy says do it, it still doesn't get done. And then when neither of them said do it, it definitely doesn't get done. So, you know, what I tell my friends is I'm just a simple country boy from South Carolina. I can't understand policy. It's too sophisticated for me. But I can count. I know how to count money, and I think all too often that's what determines policy. Now, you were talking about, specifically about the idea of health behavior in terms of policy. I think that health behavior is something that we need to bring in sociologists and psychologists to help us out. And unfortunately, there aren't enough sociologists and psychologists who are really interested in these areas. right now to move that agenda as quickly as we think is important, especially also anthropologists. These are skills that could really move this agenda along very quickly, quicker than it's being done right now, and we have to do something about getting people's interest. And then the last thing I would say is that if you're hoping to live very well, then you will work on policy for some large corporation or federal or government agency. If you want to make a difference, change the policy, the advocacy, you will not live as well. You will be probably in a low-income group like so many of us. But that is what would make the difference. The skills of policy being used to achieve advocacy is what I think will really make a difference over the next 10 years. So make that choice for me about whether you want to live well or make a difference.
Okay.
Thank you, caller. We also have some other email questions. One is, Dr. Jenkins, do we know enough right now to address health disparities in order to eliminate them? And if not, where should we be doing research?
We know enough to make a bigger impact than we're presently making. That's for sure. But there's still a lot of research to do. I think that culture is definitely one of those areas in which we have just started to break the ground. There aren't even models out there for us to look at. Insufficient numbers with diversity of ideas for us to really put that together. And so I would say culture is something that we really need to begin to do some research. People are very uncomfortable about doing research on discrimination and racism, both internal racism and external racism. Internal racism is something that we're going to really have to struggle with because the fact of the matter is it is the people who are oppressed by this sort of racist system that need to do that work, but are not often willing to do that kind of work. And so that's going to be very difficult. But people like Kamara Jones at CDC, who's been studying racism and its impact on health disparities for the last at least 8 or 9 years, clearly has already broken ground on what needs to be done in that area. And they have, I think it's called a working group on racism there at the Centers for Disease Control that has moved that agenda along quite a bit. But there's no working group right now on culture and health disparities. So I think that that's what it needs to be done. On SES, there's still work to be done there. The British and the Canadians are way out ahead of us on this area. So there's a large amount of research being done. And I said before, Nancy Krieger at Harvard is probably the single most person who's leading the way in that area. But unfortunately, in the cultural area, we don't have people. So those are the areas that I would suggest that, that we look at.
Thank you. We have 2 questions, one from a caller in Houston, Texas, and an email question. We'll take the caller from Houston first. Go ahead, please.
Yes, good afternoon. My name is Esther Sherman. I am a nursing professor at Prairie View A&M College of Nursing. And I just wanted to address the question of accessibility versus acceptability. And I was wondering what can be done at this particular time to make people feel accepted when they need health care. What can we do to make them feel comfortable when they come into the healthcare area? my reason for this is that I'm a nurse, and most of the time when minority people needs help, the nurses are the first ones that they come in contact with. And so what I would like to know is, what are some of the suggestions? I know we're dealing with culture, we're dealing with diversity, but obviously there is something that's missing.
Well, the first thing I would say is to get physicians to act more like nurses. Because I think that you're right. I think nurses address this issue probably more than any other professional group. And that's why they're so important in the delivery of health care. That's the first thing I would say. Accessibility or acceptability is, again, one of those areas where we just haven't seen enough of the work. Those things, you know, that little study about the receptionist that was done some years ago, we haven't seen more of that. We do know, when looking at the issue of cultural competence, people talk about cultural competence as if they already know the answer. And there's not enough research to understand what we really mean by cultural competence. I do know from my own personal experience, as I said before, that one should not be racist when one is judging cultural competence, which is to say that one should not assume that a person has cultural competence just because they have melanin or because they come from some specific ethnic group. I do think all of us need to be trained in cultural competence and sensitivity towards other people. And I would say that, you know, for example, early on in the HIV epidemic, and when we were funding HIV community-based organizations, we found that after a few years, we found that a large number of the resources were going to Cuban Americans, and I think that that's, you know, a good thing. And a small amount was going to Mexican Americans, and an even smaller amount was going to Puerto Rican Americans. The problem is most of the HIV were in Puerto Rican Americans, and those were the ones who were getting the least amount of the money within that Hispanic coalition. And so I think we need to be very sensitive to our, first, looking at culture, differences in culture. Number two, addressing those differences in as specific a way as possible. And then begin to do the research necessary in order to tweak our activities in that area. But there's still so much work that needs to be done in that area, because too many people make assumptions about it rather than actually doing the research.
You think these cultural sensitivity issues should be addressed nationally with all partners, i.e. nurses, epidemiologists, doctors, and all of us who provide nursing health care?
Yeah, absolutely. But I also think that, you know, there ought to be regional gatherings to talk about the issues that are unique to particular regional areas as well. I think right now what people are doing is sort of a, you know, building a cultural competence suit and one size fits all. And I don't think that that is going to work very well. I think there's some general clues about language that I think is important. But I think that beyond that, as one begins to look more deeply, it's going to be a greater variety of factors that we need to understand in more intimate detail.
Okay, thank you so much.
Thank you.
Thank you, caller. We have an email question and a couple of questions from the audience. I'll take the question from the audience first. I'll go with the woman in the back.
You mentioned
Please say your name, please.
Gracie Boswell.
Thank you.
You mentioned cultural competence as something that you can train individuals in this. And I know that there are some who believe that this is not possible to train people in cultural competence. As a sociologist, I think I would wonder about the life course perspective and what role that might play in trying to understand the origins of this incompetence culturally. Because I just wonder how what program could one actually be exposed to that would provide them with what might be lacking over a life course.
Right. Well, you're probably too young to remember Mississippi before 1960. But, people, European Americans were not known for their friendliness towards African Americans there during that period. And I would not say that everyone has changed in their heart, but if you go there now, people are more welcoming. And so I'm not saying that training can only train. It can't change. But it can affect behavior. And to the extent that training could be used to affect behavior until we could get at a deeper level of appreciation of each other, I think that is what we have to try to work towards at this point. Because not doing the simple things now means that too many of us delay in seeking health care simply because the person was rude to us. And I'll give you another example. I think most of us know how McDonald's clerks are trained. When you walk into a McDonald's, people are trained to say, "Hello, welcome to McDonald's, how may I help you?" And whether they mean it or not, it sounds like you're being welcomed into McDonald's. And in my neighborhood, I remember driving up to a window on a Saturday morning with my daughter, and the woman on the other end said, "What you want?" That wasn't very welcoming. Obviously, she was not trained, And if she was trained, 3 weeks later, she might still say, "Hello, welcome McDonald's, how may I help you?" And she might have felt the same way she did 3 weeks before. But I would have felt more welcomed if she was trained and just said, "Hello, welcome to McDonald's, how can I help you?" And so, yes, it's scratching the surface, but that might be all we could do at this point.
We had another question from the audience.
To someone who's not familiar with this topic, how would you explain the importance of health disparities? I think the example about the infant mortality rates that Dr. Schoenbach was talking about, where you do see a dramatic decline and there's less of a burden, but there's still a gap. Why is that so important?
Well, I remember this sort of offhanded taping that occurred on CNN once, some years ago, where our president was attending a meeting and the issue was health. And they got into a discussion about infant mortality. And the president basically said, what you're supposed to say, we have the best medical care system in the world. And then somebody was saying, well, but you're 17th in infant mortality and you're X and this and you're, well, we have the most expensive medical care system in the world. Well, that's true. We do have the most expensive medical care system in the world. But it's not necessarily the best medical care system in the world. And in fact, countries like Cuba, who we almost laugh at or denigrate, actually provide better medical care in the preventive areas than we do. And so, so they can reduce their infant mortality rate to a much lower level than we can They can increase their literacy rate. They can increase the number of physicians being trained until they not only train physicians, they export physicians. While we struggle with issues about so-called accessibility. So, you know, I just think that these issues are simple at one level and complicated at another. And I think biostatisticians might argue about slopes and stuff like that. But at another level, there are simpler questions that we kind of know the answer to and that we still need more research to solve. And these simple questions may have a huge impact in the end. So I don't know whether that completely answers your question, but you want to...
I guess so, but just if you could get everybody down to a really low level that was the best in the world, but there was still a difference between subgroups,
Right.
would that be satisfactory?
Oh.
Or is there
Yeah,
something
there are
more?
always going to be differences because we don't want to change people's culture, you know, and some of those factors are factors that we may trade off, you know. I grew up on the Sea Islands. I'm Geechee. I grew up speaking Gullah. I could tell, and I had to go to this school who made me take speech for 2 years so that other people could understand what I had to say. Sometimes I regret that a great deal. You know, sometimes the trade-offs may be more than we might think. When we grew up on the Sea Islands, malaria was a real problem. So the Centers for Disease came in, provided DDT, and the mosquitoes disappeared. We no longer have malaria on the Sea Islands. And then a lot of very rich European Americans came, and we no longer have the Sea Islands. So, you know, at some point you have to make trade-offs. And I think we have to give thought to that. And I don't know where we stop exactly, but I know we can get it down below what we have now.
We have time for one last question, and we're going to actually go 5 minutes into the break, so we're going to go to 2:55 Eastern Time. So we're going to take one more question from the audience.
I should have introduced myself. I'm Vic Schoenbach. You, of course, know that. Two things. The first one is we don't want people to get a misunderstanding about the Tuskegee study.
Mm-hmm.
You emphasized their cultural competence and their
Right.
response rate.
Right.
But you didn't mention the fact that, of course, that was before the human subjects rules, which meant that you had the right to withdraw from a study if you wanted to.
Right. Yeah.
But I was going to ask if you could take a few minutes to tell people the story of how the Tuskegee study was broken to the press and your role in that.
That's not something I talk about a great deal.
Well, if you want to, if you'd be willing to, I think it would be.
I think there probably were a number of us who in the early days felt that it was not a good thing. And we did whatever we could to end it. And we certainly made some efforts to do that in our group that ran a newsletter. But clearly, Peter Buxom, who now lives in San Francisco, was the person who made that first breakthrough. And once he made that first breakthrough with that article in the Washington, not the Washington Post, I guess it was the Star, it allowed the rest of us to come forward. Because we would contact newspaper reporters and we'd say, but you don't see what's wrong with this? And they wouldn't see it. People just would not see what was wrong with it. And that was a very difficult period, I think, for some of us. But, and that's why our young people need to understand that the only way to ensure that we continue to work in our communities and we continue to do it in a way that is ethical is to have young people ask questions. You know, it's really, you know, unethical things like the Tuskegee study sneaks up on you. That's the thing that's so insidious about it. It's not like even the first time I heard about it, I didn't get it. The only thing I knew was that the person who was telling me was somebody who did not feel like being in the same room with me. I had this sort of black militant, reputation of jumping on tables and stuff. And I know he felt very uncomfortable. And I thought, if it's that important to him to tell me about this, then it must really be important. And it was only by asking question and asking question and asking question that we came to the conclusion that there was something wrong. What amazes me about young people today is that they hear Tuskegee study and say, oh, that was evil. As if, oh, I knew that. I would have known that the minute I heard about it, No, it doesn't happen like that. It happens slowly. And that's one of two reasons that young people need to try to maintain their cultural sense as they get trained at places like UNC or Harvard or Georgetown, that we continue to maintain our cultural connection, because it is from that cultural connection that we will really see the questions that will take us forward in health disparities research and in a number of other areas. If we just stamp out the same standard person time and time again with a Ph.D. in whatever, all they will do is continue to repeat the same research over and over and over again. There will be no innovation. And I don't mean this just for Black Americans, but for Irish Americans and Appalachian Americans and all kinds of Americans. Keep that culture, because that's going to be your edge to asking the right question. And, that's the thing that's important, as Albert Einstein said, that it is not in answering questions. We have these students now who can answer questions like a zoo, okay? But the really important thing is having students who can ask new questions that knock you on your heel and say, God, I never thought of that before. That's the kind of student that, that I hope all of y'all are going to be.
We're out of time. Please join me in thanking Dr. Jenkins for a very provocative talk. We're going to adjourn now for a break, and we'll come back at 3:05 Eastern Time. Please join us for this afternoon's session. Thank you.